Lady, oh, okay. Welcome, ladies. We're very, very happy to have Barbara Scott with us this morning. Just a couple housekeeping rules first. If you can make sure that you are muted while she's doing the actual presentation, you can, in the chat, hopefully everybody knows the chat. Down at the bottom of your screen, you can write a note in chat, and Barbara can answer that as she goes along, or she's okay if you unmute, ask the question, and then mute yourself again is fine too. So we will be recording the session as you just heard, and I'd like to introduce sorry, I had to get rid of a little screen thing there. Barbara Scott from Devon in the UK. She's been a practicing reflexologist for over 20 years. She is the founder and chair of ARR, which stands for Association of Reproductive Reflexologists. She's been training reflexologists all around the world. She's spoken globally, and she has a very integrative approach to supporting couples having difficulties with conceiving, and supports both men and women on their journey to parenthood. She has a lovely book, which I've read, called Reflexology for Fertility. And she's the winner of the FHT, which stands for Federation of Holistic Therapists. She was the Complementary Therapist of the Year Award in 2017. And she's also a winner of the AOR, Association of Reflexologists, Innovation in Reflexology Award in 2019. And maybe those are her awards behind her shoulder there.
They are actually, they are, yes.
There you go. So we would like to thank Barbara Scott very much for sharing your knowledge with RRCO. And we'll hand it over to you.
Oh, thank you so much, Dale, for such a lovely introduction. That's really kind of you. Firstly, I just want to say I'm absolutely delighted to be here, and thank you so much for asking me to come and speak for you. It's a real joy, and I get to talk about something that I think as we go through, you'll find I'm absolutely passionate about. I like to start with a little introduction, because I always, when I'm teaching, I always like to know how people came to be involved in reflexology, because we've all got a lovely story and a lovely journey. And so I just give a little précis of kind of how I came to be doing this. So I always say my background is in something entirely different. So it was in what is now called IT, but it wasn't called that then, and it was 40 years ago, and computers filled whole rooms. But interestingly, what it did was it gave me a very logical, analytical approach to reflexology when I was introduced to it, and actually that kind of continued in with my training. So I trained with Nicola Hall of the British Reflexology Association, the Bailey School, and she took over training at the school from Doreen Bailey, who was accredited with bringing reflexology to the UK in 1960. And she also had a very clinical approach to reflexology. So she had been training as a doctor herself. So yeah, it was very clinically based. So I kind of had those two things kind of combined to give me this, yeah, very sort of analytical approach to what I was doing when I came to reflexology. So I went off and did my training in the very early 90s, and little did I know, but my very, very first client was someone who had both fertility issues and repeat miscarriage. So I didn't know that my path was set right from the beginning, but all I did know at the time was that I really didn't know enough. And we didn't have CPD courses then. So I was very much on my own, and I realized that I just needed to keep reading and researching, because as a result of that lovely first client, who I'm still in touch with for very different reasons now, she's past her reproductive years, but as a result of that, of course, lots of other clients came to see me with different reproductive issues and different issues with trying to conceive. And so I had to continue my research and development of my knowledge. And so gradually over the years, there were still no CPD courses, and I was still searching for them. And in 2007, I wondered if anyone was interested in the approach that I had. So by this time, I had recognized that we were able to use science to evidence-base what we were able to feel in the reflex points in the feet, because these particular groups of clients, oh, sorry, Dale, CPD stands for Continuing Professional Development, which is, yeah, I think it's different for you, isn't it? It's a different terminology, but yeah, continuing education, I think you call it in Canada. Yeah. And so what was fascinating was that you might be able to feel something in a reflex point, maybe like a little ovarian cyst, and then the client would go maybe that afternoon or the next day and have a transvaginal ultrasound scan that would indeed show that in that particular ovary there was a cyst. And then, of course, I realized that we were missing what was happening with men. Men are a really important part of the picture, and they are still sadly being overlooked. And when they were, when we were getting poor results, so, poor semen analysis results, you could feel these subtle changes in the male reproductive reflex points. And gradually over time, I learned to manipulate the reflex points and change outcomes. How fascinating. And then we would see those changes being confirmed by science, by medical tests. So I always say I've got a very low boredom threshold, and this has gripped my attention for almost 30 years, because it never ceases to amaze me how reflexology is capable of changing outcomes, and how when you then combine those two things, the science and reflexology, you're able to evidence-base what you're doing. And that's what grips my attention, because it's absolutely fascinating. So in 2007, I had developed a range of protocols, and so I thought, well, I can't find anything more to teach, anything else to teach me. I wonder if anyone else might be interested in what I'm doing. So I decided to write a course. And I always say that I feel as if I am the guardian of this information, because I wrote the course in 3 weeks, and all I can say is it flowed through me. Rather than me writing it, it just flowed. And so I ran the course in 3 little tiny courses around the UK, because I wanted to see whether it worked for other practitioners, whether they found it interesting, or whether it was sustainable, all of those things. And here we are in 2021, and we're still going. But what I did realize was that even though the course itself has a lot of content, I was actually only able to teach the basics, and that these practitioners needed ongoing support and education. So in 2011, along with 17 of our practitioners, we formed the Association of Reproductive Reflexologists. And this year in October, we celebrate our 10th anniversary. So we're very excited about that. And I went into it with 3 objectives. One was to continue to support practitioners. The second was to continue education. And the third was to actually promote what we were doing to the medical practice. And I'm really pleased to say that we've succeeded in doing all of those things. So we have a lot of collaborations with scientists and fertility clinics in terms of making sure that we have this patient-centered approach. So we put the patient in the middle, and reflexology is one of those things, but we refer on to medical practice and engage and make sure our clients get the best possible help and care that they possibly can. We bring in lots of speakers, so we run lecture days and webinars on a wide variety of topics. So we've had professors of reproductive medicine talking about male fertility, specific female issues, looking at things like polycystic ovarian syndrome and endometriosis and ovarian cysts, and then looking at male factor issues. So it means that continuing development of knowledge is available for our practitioners. And then we attend the fertility show in London every year. We have a stand and I usually speak, and I've spoken on many occasions just to get the word out there that reproductive reflexology is a good support for for anybody who is going through a fertility journey. And that can mean a heterosexual couple, it can be a single person, whether that be male or female, or it can be a same-sex couple. So a lot of the discussions we have when we're training about is who is it you're actually supporting, because you'll need to adapt your support to that particular person. So yeah, just I think that's probably enough of an introduction. And what I'm going to do is I'm going to just share my screen and just kind of talk you through what we're going to cover today. So just bear with me while I do that. Here we go. There we are. So I'm hoping everyone can see that okay. Just shout if you can't. Is that okay, Carol? Great, lovely, thanks, Dale. Okay, so I like to describe this as an integrative approach to fertility. So what is it, first of all? It's evidence-based, it's integrative, and it's looking at working with both men and women. So what we need is then an understanding and treatment of a wide range of reproductive conditions, because they can impact upon fertility for both men and women. And we use very safe, very structured, measured treatment protocols integrated with allopathic medicine. So it's very much this patient-centered integrative approach to fertility. And as I say, reflexology is just a part of what might happen for them. So I want to talk about what reproductive reflexology is, the kinds of evidence base that we use, the consultation process that we use, because that's really, really important. And then I've got some data that I like to share as well. And I'm hoping, as I was saying earlier, I forgot to add this bit in. So one of the things that's really important for the medical profession to accept what we're doing is research and data. Now we have some data, but I have for my sins embarked on a doctorate so that we can collect more data and do some research. I mean, we have a fantastic data collection that we did. And, my thinking is probably we will develop that and engage all of our practitioners in that process, so that what that means is we have a bigger study which will have larger numbers and therefore is much more likely to be accepted by the medical profession. But I'll come back and talk about that afterwards. So some of the first things are, we actually aim to identify what the issues are, because if we know what the issues are, it means that we can fine-tune what we're doing as practitioners. And it's really, really important to understand that we need to treat both men and women. If you've got a heterosexual couple, you tend to find that the men are overlooked, even now, and even with we've got some amazing developments in technology for male fertility, and they are still not used in fertility clinics. And sadly, there is the general public tend to think that, well, if I can't get pregnant, I'll have IVF. And the success rates for IVF are only 25%. That means that 75% of all cases will not work. And that's sad. And you know, we need to be able to support these couples to make sure we find out what are the causal factors, what is it that is preventing them from getting pregnant. And so what we need to do as reflexologists is use this integrative approach, and that means using medical testing. We use basal body temperature charting. I'm going to talk about that and give you a little example, so that we can understand the causal factors and measure progress. And it's about not being afraid of science. It's about not being afraid of using those measuring tools and using them to support our clients in a really effective way, because it helps them to understand what's happening for them on an individual basis. So that's really important. So this is UK, but realistically, globally, we have at least 1 in 6 couples who are having difficulties conceiving. And my view is that the numbers are much higher than that, because these are the couples that present for medical treatment. We know that there are many more who find that intimidating, who don't want to go down that path, and therefore are not registered. So I think it's much more likely to be 1 in 4 or 1 in 5 couples who are having difficulties conceiving. And we know that that's increasing. When we're looking at causal factors, it's a third male, a third female, and a third joint. And that isn't just about difficulties conceiving, it is also about early miscarriage as well. So it is about understanding that men are involved in at least 50% of all cases of fertility issues and early miscarriage. You know, when I'm teaching this, the DNA which is in the egg and in the sperm, which when they're fertilized, melds together to form those chromosome development. You know, if you've got faulty chromosomes in male sperm, in the DNA in the head of the sperm, it is as likely to be part of the issue as the female. But because women carry the baby, all focus is on her, and we need to shift away from that. It's really important. Yep. So there was a study. This is interesting. So male fertility, they looked at a 25-year period and found that male fertility during that time, the quality of sperm had declined by 50%, 50. What they're now saying, because that decline is continuing, is that by the year 2040, as a as a global community, we're going to have real difficulties with maintaining our population. Now, there's a lot of discussion about that, and I don't get time to cover it now. But just briefly to say that, of course, there are concerns that the population, the planet is overpopulated, but we also need a certain amount of population to continue to support the lifestyle that we have. And that's from a financial point of view, it's from an educational point of view, it's from a practical point of view. And if that starts to decline rapidly, which is what's happening, then the life as we know it at the moment is going to be very, very different. And so we need to be aware of politically how that is managed. So you can see that this goes beyond just reflexology. It's about looking at the global issues. As I say, fertility clinics overlook the male factor. And that's really, I think that as practitioners, we are in a very unique position to make sure that men are not overlooked and that they are included in the equation and that they get the correct and appropriate testing. Really important. So we aim to identify causes before treatment. We form these collaborations with fertility clinics and other medical test providers. This integrative approach, which includes looking at medical tests, and we have an assessment called a repro assessment, which is a little diagnostic tool which involves looking at the color of the feet, feeling temperature, and feeling the reproductive reflex points on the feet to make sure, so it gives us an understanding of general health and well-being, and whether the reproductive system in women is functioning as it should throughout the menstrual cycle, and in men whether there are any anomalies. So that's part of our initial consultation process. So we also aim to treat a wide range of conditions which might impact upon fertility. So that's like regulating the menstrual cycle. That's one of the most common things, improving sperm function and production, making sure there are adequate numbers, that they're moving well enough and they're formed really well. And just very simple things like elevated stress levels can impact upon how well sperm are functioning. So, you know, even if all we're doing is reducing stress levels, we're going to have a positive impact upon sperm production. So we use very prescriptive treatment protocols for both men and women, and they are designed to either mimic what should be happening in the menstrual cycle at that particular time, or they are designed to override a particular condition that is creating an issue. So we are in a way manipulating reflex points to improve fertility health. So they're very, very structured, which makes them safe, and it also makes them measurable. So when you're coming to do research, you need something that is always the same, so that you can measure what effect that is actually having. You start doing other things, then it might be that other thing that is impacting. So if we're using a structured protocol, it makes it much more easily measurable. And we also work to support all forms of assisted conception, so medicated cycles through to IVF. And this is where we kind of turn reflexology on its head, because all of us have been educated into using reflexology to support the body in what it should naturally be doing. Now, we can't do that in assisted conception because clients are taking really powerful drug protocols, and what we need to do is mimic what the drugs are trying to achieve. So therefore we need to understand what drugs are being used, what they're setting out to do, and then we use a treatment protocol that supports that process. Going through assisted conception is a huge decision to make, and so what we want to do is make sure that we are not doing anything that might interfere with how that drug protocol is working. So we use protocols that are designed to support the drug protocols. So we use an initial consultation process. Now, everybody does this, but ours is slightly different. And it's slightly different for a really good reason. Quite a lot of fertility clients have either got a very complex picture, or they've been trying for a long time, or there are issues that have been overlooked even by fertility clinics. And so what we need is really thorough information gathering, and we need the right pieces of information. So we have, I haven't got a copy in front of me, but we have a preconceptual questionnaire which we send out to our clients before they come to see us, which runs to 9 pages of questions. And that's the kind of skeleton upon which we build our initial consultation process with them. So along with that, we ask clients to bring with them copies of relevant test results. So there are particular tests that they might have had: follicle stimulating hormone, luteinizing hormone, progesterone levels, prolactin, estradiol for women, and semen analysis results for men. So when I'm teaching, we actually teach how to interpret those and how to understand whether, you know, what you've got is someone who is within parameter or is outside of, and then might need referring on for more support and more investigation. So we ask clients if they've got that information to bring it along with them, to bring copies along. And our initial, our consultation is consultation only, because what we need to do is gather as much information as we possibly can, because that will guide us in terms of what we need to be doing in planning treatment. So we talk about their fertility history, their gynae history, general medical history, based upon the information that they've provided. We talk, for women, we need to know lots and lots and lots about their menstrual cycle, because that will help us to understand whether there are any issues there. So length of their cycle, the length of their bleed, whether they recognize any signs of ovulation, and whether they get any PMS symptoms. So we know that if women are not recognizing ovulation signs, they may well not be ovulating. You can have someone having a very regular cycle and might be having regular bleeds, but they're not ovulating within that. So we need to make sure that they are. And women who get extreme PMS, it would tell us that there was an issue with the luteal phase, the second half of their cycle. And again, that might be causing difficulties. Apart from it being really unpleasant, it might cause problems for them in terms of them getting pregnant. We want to know whether they're getting spotting or breakthrough bleeding prior to their bleed, because that would tell us that there might be an issue with progesterone levels. Again, that would cause issues with sustaining, maintaining a pregnancy. And we need to look at what their bleed is like. So is it really heavy, dark, brown, clotty? That would tell us there's lots of stagnation. The endometrium is not clearing out very well. That again would have a knock-on effect on how their cycle functions and may be impacting upon their ability to get pregnant. So we need to ask lots and lots of information to build up a picture of what's happening for them. We also talk about, in very general terms, diet, nutrition and lifestyle. Now, most of us are not nutritionally trained. So what we've done is collaborated with Dr. Marilyn Glenville, who's a very highly regarded nutritionist. She has a doctorate in nutrition, and she specializes in this area. So it means that what we've got is some sensible advice that we can give to our clients that will help support them in a way, putting them back in the driving seat, helping them to make their journey more successful. And we know that with fertility issues that it's stressful because it's something that becomes outside of our control as human beings, and that makes it incredibly difficult. So if what you're doing is saying, here are some things you can do yourself, which have research behind them, and we know that they support fertility, it means that it's about empowering that client to support themselves on their own journey. So the repro assessment I've talked about, so we carry that out at the end. It only takes 5 or 10 minutes, so we do that. And then once we've got the results of that and all the data that they've brought with them and the questionnaire, we can then start planning treatment. And the treatment is very structured depending upon what the issues are. So it means you're able to have a discussion with your clients about when you would need to see them, how frequently you would need to see them, what you're going to be doing with them. You can talk about charting their cycle, about setting homework for them, etc., etc. So you've got this very structured package of care, actually, which makes them feel quite supported and engages them in the process of the treatment plan. And what we also then do is sometimes signpost them back to their doctor, onto a fertility clinic, or some of the other science-based testing that we collaborate with to make sure that they're getting the most appropriate assessments that may have been overlooked. We have to remember that most general practitioner doctors might not have fertility as their specialist field. They might not be that interested in it, and therefore their knowledge can be quite limited. And so I do think that we have a really important role to play in this area. Please do ask questions. If you've got something you want to add, please do. I love questions, so please do ask questions. So what I've got to kind of make it a little bit more real is a couple of examples, one female and one male, just so that hopefully it will all make a little bit more sense. So I'm going to go through these, and then I hope you're not going to get too bored, but I'm hoping it just kind of brings it to life a little bit. So this is actually a client of mine who's very kindly allowed me to share her charts, which I'm going to talk to you about in a moment. But she had issue with the luteal phase of her menstrual cycle. So this is the period of time from ovulation to bleed. It's when we should be producing nice high levels of progesterone, which supports implantation of any fertilized embryo and continues to support pregnancy. With this particular client, she had PMS symptoms, she had headaches, she was getting spotting, breakthrough bleeding in the lead up to her cycle. And when we did her basal body temperature chart, we could see that her progesterone levels were falling. So this is where we're starting to use some science to underpin what we're doing. So we're going to have a little look at her chart. But so this is a handout or a document that was produced here in the UK by the Faculty of Sexual and Reproductive Healthcare at the Royal College of Obstetricians and Gynecologists, and it's fertility awareness methods. And this is what we rely on when we are working with our clients. So they use a different, it just looks slightly different. I use a free website and also a wonderful piece of technology, which I'm going to talk about. So let me just go backwards and just talk. So this method uses the basal body temperature. So basically what it means is that clients have to, first thing they do every morning before they get out of bed, eat, speak, drink, anything, is take their temperature under their tongue. So when we go to sleep at night, our body temperature drops to its lowest level. And if we take it the moment we open our eyes, then we start to gain an accurate recording. And what happens is, the moment women have ovulated, their progesterone level rises just by a few points of a degree. If you look here, you will see this is the moment of ovulation here. It's just a rise of 1, 2, 3 points of a degree. They're minute changes, but if we chart them, we can see the changes taking place, and we can see that this woman has got a lovely steady progression of progesterone post-ovulation. However, for some women, it's very, very difficult to do that. So there is another lovely piece of kit called OvuSense. And actually, if you bear with me, I've got my little sample here. And this records core body temperature. So basically, it produces a chart, which you can see, it's not a very good image, this. I don't know why it's distorted itself, but it draws the chart for you. And what you've got is this lovely little piece of kit, which is about the size of a tampon, actually. Vagina sits in there quite comfortably, and it takes the core body temperature every 5 minutes throughout the night, removed in the morning, washed, held over the app on the mobile phone. It downloads all the data, creates a median temperature, and creates a chart. It's much more accurate, but some women don't like it, so we work with either. This is fab, and I'm hoping to use actually this in maybe part of the research that I do, because it's such a fab piece of kit. The bottom line is it provides us with information. And this is a wonderful free app called fertilityfriend.com. And I use this with a lot of my clients. So I'm just going to talk you through briefly what it is. So I'm going to draw all over this. So each of these little blue dots is a recorded temperature. Okay, so your client takes the temperature every day. The little dashes mean they've forgotten to take it. The open circles, or sometimes what you get is little arrows now, means that it might not be reliable. So they might have hopped out of bed first, or they've not had sufficient sleep, or they've had disturbed sleep. So you know it might be an unreliable recording of temperature. Along the bottom, we have the day of their menstrual cycle. Along the top, we have the date. Underneath that, we have CM, which stands for cervical mucus, so that they can plot the changes in the cervical mucus. They can make their own little notes on changes in symptoms. And BD stands for baby dance. So it's just a very lovely way of saying they've had sex. And actually, it's really, really important, because when you are working with these couples, sometimes they forget that they have to do that to actually have a baby. And so we have a lot of discussions about, you know, having sex at the right time, but not placing too much pressure and all of those things. So actually, it's a lovely way of them plotting it on their graph without you having to ask when and whether they have had sex. So that works really well. So what you can see is that we've got this red crossbar, which is when the algorithm thinks that ovulation has occurred. Now, it is totally reliant on the information that it receives, and therefore the information that a client will input. And so I am, when we come to talking about this particular chart, I'm going to disagree with when ovulation has occurred. What also happens is a woman can record changes in her cervical mucus. So we know that leading up to ovulation, the cervical mucus should change. It should become clear and stretchy and profuse and more sperm friendly. She can also record any other changes that take place in her chart. Now, this particular woman came to see me and said, I have a regular 28-day cycle. I don't want to do charting. It's too stressful. And I don't think there's any merit in me doing it. So I pleaded with her and said, just for me, would you do 1 month? So that we can just, if everything's fine, we can ditch that and say that's really not the issue. But if we could just do 1 month, that would be fantastic. So that's what we did. And what you can see is she does actually have fantastically a 28-day cycle. But in actual fact, she didn't ovulate until day 20. Okay. Because this is where you can see the steep rise in her temperature, which takes her basal body temperature above her baseline. Okay. And then what we've got is lots of fluctuating, so not very stable progesterone, and it's too short. So we've got 1, 2, 3, 4, 5, 6, 7, only 8 days in her luteal phase before her next bleed starts. And it needs to be at least 10 days. I usually like it to be 11 or 12. So that means even if they had, as a couple, fertilized an ovum, it was really not going to have the best chance of implanting, and certainly maintaining a pregnancy with that level of progesterone issue is going to be almost impossible. In addition to that, we can see that she is not producing the right kind of cervical mucus in the lead up to ovulation. It should be here. And these little asterisks mean spotting. So that ties in with the progesterone deficiency. Okay, so she's a little bit, the spotting indicates that she's got unstable progesterone and her endometrium, the lining of her uterus, is breaking down too soon before her bleed. So we could see herein lay the problem. So she suddenly became fascinated because we could see that there was a causal factor for her difficulties with fertility. So we worked with her, and these are some of the things that we did. We worked with her weekly throughout her menstrual cycle using different protocols to manage each stage. So differently during her bleed, from end of bleed to ovulation, 5 to 7 days post-ovulation, and then the week leading up to her next bleed. What we did was, because she specifically had issues with progesterone, we wanted to encourage the corpus luteum, which forms in the follicle post-ovulation and produces progesterone. We wanted to encourage it to secrete more progesterone. So it's one of the very few times when you would stimulate the ovary reflex point post-ovulation, but we're doing it for a really important reason. We want to encourage increased production of progesterone. And what we also did was we taught her how to stimulate the ovary reflex point on her hand, and we got her doing this 5 times a day for 90 seconds each side, both hands. So we got her self-stimulating her ovary reflex point. So what did we see? We saw a huge improvement in her symptoms. Her PMS improved, the spotting disappeared, and so did the cyclical headaches. We saw changes in her basal body temperature charts, which I'll show you in a moment, and her repeat progesterone test, which is taken 7 days post-ovulation, was much improved. This was her chart 2 months later. Okay, so the exciting thing about this is that this is where you're using science to evidence-base the effects that reflexology is having upon your client's menstrual cycle. So the first thing to say, just get my little pen, is that we've got her ovulating on day 12 now rather than day 20. She's producing, E stands for egg white cervical mucus, so 5 days of lovely egg white cervical mucus in the lead up to ovulation, which is exactly what needs to happen. We need to have sperm in situ before ovulation in the right kind of cervical mucus. Most of the time, cervical mucus is hostile to sperm. It's too acidic and it changes its pH, among other things, in the lead up to ovulation. So it changes its consistency. And so we could see those changes had taken place. We've got a lovely rise and then another rise, and then it stays elevated for 16 days. So she's now got a 16-day luteal phase, and we've got rid of all the spotting. So here we are using an evidence base along with her symptoms to see that we can see these changes in her menstrual cycle. And what we can also see, thankfully, is that they had sex at the right time, twice during the lead up to ovulation. Okay, so for me, this is what makes it so exciting, is that you're actually able to, along with seeing your client's symptoms change, you're able to measure that progress. So here we have the reflex points on the hand. This is a little chart I give out to my clients. Here we have the reflex points on the feet. Now I'm just going to show you quickly how we do this. So when we're taught, we're all taught that ovary reflex points are all in a standard place. And the thing to say here is they absolutely are not, because when you look at the reproductive organs, they don't sit with a uterus in the middle and 2 lovely, neatly placed ovaries either side. Ovaries can be tucked behind a uterus, in front, slightly higher up, slightly lower down, and it's learning to feel for those in the ovary reflex points. And you might find that you've got one in one place on the left side, and it will be somewhere completely different on the right hand side. So, you know, when we're teaching, we teach you kind of how to feel for where that ovary reflex point is, because sometimes it can be, you know, far back and tucked behind. The uterus is slightly different, but what you can see on my lovely foot here is I've got 2 positions for the uterus. So one is a normal anteverted uterus, and this is a retroverted uterus. It's tilted back slightly, and that can sometimes cause a problem with getting sperm to where they need to be. So I've got lovely Harriet, who also teaches for me, and she is a visual learner, and she has drawn these beautiful charts for us so that you can see where we have placed these on the reflex points, but with the understanding that actually sometimes they're slightly different to that. So it's an individualized approach to each particular client. So I'm just going to use a quick example for working with men. So treatment for men is looking at improving any underlying condition, but also looking at sperm quality and quantity, because that is obviously really important. And we look for things like Hydroceles, so fluid around the testes, they're very easily palpable in the reflex points. Varicoceles, little varicose veins, they also cause a problem, and you can see them on the reflex points. Inflammation of the epididymis, again, you can usually see and feel that on the reflex points. We'd like them to have a semen analysis when they come to see us if they've been trying for a while, because that gives us some information about what might be the issues. And we work on reducing stress, because we know that stress damages DNA in sperm. So with men, we're very much working with reproductive and endocrine systems. We rely on, when we're interpreting semen analysis, the World Health Organization reference ranges for interpreting semen analysis. And again, we cover this on the course, but you can see that we look at the amount that's being produced, how many sperm there are per mil that's being produced, the total number of sperm that are in an ejaculate, and the motility, the movement of the sperm. There needs to be minimum numbers moving, and minimum numbers that are actually alive, and minimum numbers that are normally formed. And so again, we teach this in training, but and it's about understanding when it's appropriate to refer on for further testing, more detailed testing. So the male case study was probably one of my most complicated cases ever. This couple had been trying to conceive for 11.5 years when they came to see me, and they'd had, she had an irregular cycle. She was a nurse at the local hospital working a very irregular shift pattern, so we worked to correct that. But the male was incredibly stressed, and he had very high levels of prolactin. So prolactin is a hormone that's produced by the anterior pituitary gland, and when it's very high, it suppresses the production of FSH and LH, follicle stimulating hormone, luteinizing hormone. And that in turn, in men, suppresses the production of testosterone. And testosterone is the hormone that is responsible for the production of sperm. So not only that, he had a poor sample, but he also had erectile dysfunction, which is commonly associated to high prolactin levels in men. But this had been overlooked by the medical profession. And so they'd been sent straight for assisted conception. So they'd had 2 rounds of IUI, 3 rounds of ICSI, intracytoplasmic sperm injection, 1 of IVF, and a frozen embryo transfer. Not one success. So that is a huge amount of treatment they'd been through with not even a pregnancy. And that was, they came as a complete last resort. So what you can see here, and it's very difficult because these are thankfully, I've anonymized them, but these are his results. So I've précised them for you. Actually, I just might need to go back because what we can see, no, bear with me. I have précised the results, but he had a very poor count with most of his sperm not moving. 70% of his sperm were not moving. And if they're not moving, it means they can't swim to where they need to be. So he had a very poor sample. So we use an 8-week program with men because we know that sperm take 12 weeks from their cell division through to being mature and ready in an ejaculate. And so we treat weekly for 8 weeks, and then we continue fortnightly. And then what we like to do is a repeat test. So this male, I'm just going to go on because it's easier to show you on here, but those were his results. So we increased his sperm count from 21 million sperm per mil to 40 million. So we more than doubled that. The total count went up from only 29.4 million to 80 million. So he now had a total count within normal reference ranges. The progressive motility increased from only 20% to 60%, and the percentage of non-motile sperm decreased from 70% down to 35%. So he then, his semen sample then became within normal reference ranges. So again, the exciting thing about this is that we're using science to show how effective reflexology can be. That's what makes it, for me anyway, that's what makes it so fascinating, and why it's engaged me for such a long period of time. So the outcome for them was that in March 2014, they were already embarked on another cycle of IVF. And they did get pregnant, but she developed cervical incompetence and lost the baby at 14 weeks. And so that was devastating. And interestingly, they came from Kerala in India. And so they were going back there for their IVF cycle. So I taught him what to do, because I couldn't find a reflexologist out there for them. So I got them to keep feeding the results back as they were going through the cycle, and then said, and could you now do this technique and that technique? So that was really interesting. But when they came back, very briefly, what happened was they had decided to use a surrogate. And so would I be involved in that? They had asked, and of course I was happy to do that. But she fell pregnant naturally. His erectile dysfunction had been resolved, and she fell pregnant naturally before they embarked on the cycle of treatment, and little baby boy was born in 2015. He saw her throughout her pregnancy because she did have cervical incompetence, but we treated her every 2 weeks throughout her pregnancy and managed to get her to 28 weeks of pregnancy, which was such a lovely outcome. And he's now just running around doing, I see pictures of him, and he's just lovely. So that was a really special outcome. But what we also have for our males, again, is just getting you to feel for these reflex points in very specific places, but feeling for anomalies. So looking at things where there might be a varicocele or a hydrocele, or an inflammation or disease of some kind. And we're just getting you to feel for these reflex points in minute detail to identify whether there might be issues with those. So how effective is it? This is the bit that is important. It is important. It's not the whole picture, but it is important. So we did a data collection. So we looked at 180 clients. Now, in medical terms, this is not a big sample, but in complementary medicine terms, it is a huge sample. Most research with complementary medicine is somewhere between 6 and about 30 participants. So to have this level of data is quite a big sample for complementary medicine. They had a wide age range, so they were aged between 24 and 46. And the average number of treatments was about 11 and a half. If we just put them all into a big pot, they had approximately 11 and a half treatments. Oh, I seem to have lost some of my data. Yeah, hold on. There we go. So we had, of those 180, 122 clients conceived whilst receiving reproductive reflexology. So they were using it either as a standalone or alongside their assisted conception. 100 of them conceived naturally and 22 were having IVF. So we had a success rate of 68%. Now, if you compare that to 25% with IVF, we were quite astonished that this was doing so well as a form of treatment and support. What we also discovered was that the success rate for those having IVF and ICSI was 52%. So we had more than doubled the success rate that is accepted within IVF and ICSI, which is 25%. So that, although the sample was small, that tells us that it is possibly increasing outcomes even when clients have to go through assisted conception. So that was also really interesting, and I really would like to do some more research in that area. What we then also did was we looked at different scenarios. So we looked at women who had, unexplained fertility issues, endometriosis, PCOS, amenorrhea, so having no cycle, no bleed at all, progesterone deficiency, ovarian cysts. And then we broke the data down into pregnancy rates and live birth rates. So with unexplained, 70% pregnancy rate, and then a 70% live birth rate. With endometriosis, 65% pregnancy rate, but 55% live birth rate. PCOS, 72% pregnancy rate, but we know there's an increased miscarriage rate with PCOS because the hormones are so unstable, 57%. Amenorrhea, 91% pregnancy rate, 70% live birth rate. Ovarian cysts, apparently once we'd, it was a small sample, I think, but once they were remedied and they weren't interfering with menstrual cycle and hormone response, we were getting a very good live birth rate. Progesterone deficiency, 50% pregnancy rate, but once they were pregnant, then a very good outcome. And then we looked at male fertility, so morphology and motility. And it's interesting because 50% live birth rate for both of them, but it is interesting because we know so much more now than when we did this. So we've got different protocols, and so it will be very interesting when we get to repeat this data collection to see whether we get a different outcome. We're really proud of the collaborations that we have built with all kinds of medical practitioners, and these are just some of them. Most of them have been to speak for us at some point, so they are participating in our continued development of knowledge and education. So I won't read through them all, but just, yeah, some of the collaborations we have with fertility organisations, and I do write a number of articles, which really is just about promoting what reflexology can do. And then I just like to finish with some of our anecdotal cases. I think some of them, not all of them are mine. They're from some of our practitioners because it's useful to have from, different practitioners. So this was a woman who was aged 40. She had a really high FSH, follicle stimulating hormone, and a low AMH. Now, what that means is that follicle stimulating hormone is produced by the anterior pituitary gland, and the levels should be low. It should be somewhere between about 6 and 8, sometimes up to 10. And what tends to happen is the higher it is the harder the body is having to work to get some activity, some follicle activity in the ovaries. So a high level, this higher level is really not great. And AMH stands for anti-Müllerian hormone. That is a hormone that is produced by the antral follicles, the little tiny immature eggs that are in our follicles, and they give us an indicator of the quality of the eggs and how many there might be. So this tells us very clearly that this woman would be highly unlikely to get pregnant, either naturally or with IVF. The male had very borderline morphology, so the formation of the sperm was very poor, and he had a history of using steroids in exercise. So they used basal body temperature charting before starting treatment, which showed that she was not ovulating. Okay, so she was 40, not ovulating, very poor quality eggs, and had been classified as medically infertile. So she saw her reflexologist, not me, one of our practitioners, had 4 treatments which regulated her menstrual cycle, and then within 6 weeks was pregnant. So that's quite extraordinary, because what that tells us is that we're managing to use the protocols to correct chemical and hormonal imbalances. So both of these male and female will have been treated to overcome the difficulties that they were facing. So that's really interesting. And this one was one of mine. It was fascinating. So she came to see me, this lovely, lovely female. I did work with both of them. And they'd already had 4 failed cycles of IVF. But interestingly, when they were trying to harvest from her left ovary, they could never access it. It was tucked right up behind the uterus. And so it became very difficult to access. And so what we did was each time she came, I just used a little technique to see if we could gently, very gently, maneuver the ovary into a more accessible position. And sure, and I said to her, I'm sure all the good ones are in there. So interestingly, we did that as she was going through her cycle of treatment, and they harvested 4 eggs from that particular ovary, that particular cycle. And she had a positive test, and they've now got a little girl. So we can do little tiny things that have a huge impact. And then I'll just finish with a little montage. So these are from some of our practitioners. So a couple trying to conceive for 4.5 years, conceived after 3 treatments. Another couple trying for 6 years, 3 failed IVFs, 14 treatments, and they've got a baby girl. Secondary infertility. So this woman had children, but then was perimenopausal at 37, an issue with her thyroid and endometriosis. 3 sessions and she was pregnant. Another couple who'd had 2 miscarriages, 4 failed IVFs, and testing all over the world, no conclusion, 3 treatments, pregnant naturally. Another 2 clients, both with repeated miscarriages, fell pregnant after 3 months of treatment, which resulted in live births. And then this last one, which I absolutely love, was after trying to conceive for several years, this client was told she had a 1% chance of conceiving naturally due to her egg quality. She had 8 reflexology treatments. And at this stage, when we wrote this, she was 34 weeks pregnant, having conceived naturally, which is it just shows you the power of reflexology, really, which is absolutely wonderful. Dale very kindly showed a copy of the book, which is available on Amazon, and it's just kind of got, I wrote it as if I was teaching a lovely class. And so the easiest way for me to write it was to imagine that I was able to, I was just talking to a group of people, because what I wanted to do was make the information accessible and usable, because it's pointless writing a manual if it's got all the right technical information in there, but it makes absolutely no sense and just seems like mumbo jumbo. So I've written it so that, you can just leaf through, go to the index and say, someone's going through a frozen embryo transfer, and then you can just go directly to that, and it explains what it is, and it's got structured protocols in there, but hopefully it's got lots of other information that's useful, so treating particular conditions, etc. So yeah, if you want to know a little bit more about what I do and the teaching, Seren Natural Fertility is .co.uk is my website, and our organisation is reproductivereflexologist.org, also with lots of information on there. So thank you for listening. I'm going to stop sharing my screen now, so if you've got any questions, please fire away. I hope it wasn't too boring, and I hope it made some sense and you can utilize some of it. So,
ladies, you can unmute if you want to ask directly, or you can put it in the chat.
I'll go ahead and ask if that's okay.
Oh, lovely, Sandy.
Now, I know that this is probably new and exciting that's happening with the establishment of vaccines, but have you heard or have you seen any differences in any of the women who have been vaxxed with regards to the change in their in their conceiving or changes in their premenstrual, and even people that are menopausal, any changes in that?
Oh, that's such an interesting question. And actually, we were discussing this very thing. So we have a closed Facebook page for all of our students and all of our members, so that we can safely share information, provide peer support, and have these kinds of discussions. And somebody had posted about that yesterday, and we were discussing it. So there is an ongoing study at the moment about the effects that because there's so much anecdotal evidence that the vaccination is causing issues for menstrual cycle. There was a really interesting link that I posted in the Facebook page, which shows that they are investigating that because there is so much anecdotal evidence showing that that might be an issue. So yes, we don't know. I think it's interesting because the researcher that's looking at it is saying probably more to do with hematology. It might be, but I shall follow it to see what happens. So the answer is we don't know at the moment, but certainly there's a lot of anecdotal evidence to suggest that that might be an issue. Yeah, I think they're just very reticent, Sandy, because what they don't want it to do is deter people from getting vaccinated. That would be yeah. So I think they're a bit cautious, but a really good question.
Thank you. Thank you for your answer.
Pleasure.
Hi, Barbara.
Hello.
How are you? Thank you so much for doing this today for us.
It's a pleasure.
I very much enjoyed it. Learned quite a bit. So I have a question. I do have, or I've had over, a few years, some clients that have had issues, with fertility. So do you find that there's some evidence about those that are on plant-based diets and those that are carnivores? Like, is there a difference? Do you think that maybe not eating meat could affect, infertility, or just being on plant-based could increase fertility?
I don't think that it's to do with whether they are on a plant-based or a carnivorous diet. What I do think that it is to do with is limiting foods.
Okay.
So if you have somebody, for example, who starts to really limit their intakes of essential fats, for example, then what you tend to find is that they become very lean, and they lose a lot of their, so for example, in women, they might lose a lot of their abdominal fat, and we need some of that because it produces a particular kind of estrogen that feeds into the ovaries and gets converted into estradiol. And estradiol is the form of estrogen which is used for follicle development. So my view would be, it isn't necessarily whether they eat meat or not, but I do think that a severely limiting or restrictive diet can impact upon outcomes for fertility.
Okay. And do you also work with naturopathic doctors?
We don't have them in the same way as you have them in Canada.
Okay.
So we have so one of our practitioners I know who's based in Canada, works with a naturopathic doctor in Canada, and that works really well. But we don't have the same. It doesn't work in quite the same. We do have nutritionists that we refer clients onto, but we don't have naturopathic doctors in the same way as you have in Canada.
We do have quite a lot here in Canada. And one more question. Have you had any of your clients that have had to have reproductive surgery?
Oh, yes.
And with a success rate of, getting pregnant after that?
Yes, and it will very much, I mean, I don't think I think you have to caveat that with, it depends on what surgery they were having and for what condition, and whether there was scar tissue that formed. So the thing that would spring to mind would be something like endometriosis. So that's the most common surgery, where they will remove endometrial lesions. What you have to be aware of or careful of is that they don't they don't develop something called Asherman syndrome, where you get development of scar tissue, and that limits movement of the reproductive organs and impacts upon fertility, or you get, you know, an inflammatory response as a result of, you know, the endometriosis not being resolved. And yeah, so it would depend, but we get good results with individual conditions like endometriosis, which has involved a surgical involvement.
Okay. And I was reading that also in Canada, they're saying that it's 1 in 8. They're having, you know, the infertility issue. So a little bit higher, or not as high, sorry, as in the UK, but they're saying that they're seeing a huge increase in that as well.
Yeah.
So yeah, worldwide. Yeah, and environmental as well too. So
Oh, without a shadow of a doubt.
Yeah.
Yeah. Our planet sadly is now very polluted, and it's very difficult to avoid that.
yeah. Okay, wonderful. Well, thank you for that.
It's a pleasure. That's a pleasure.
I have a question.
Yes.
I'm just curious on future pregnancies, if you've had any stories about how perhaps having had that first baby has helped them then to conceive again, or if there's just still an ongoing continuing issue, or if it's something that will help, you know, by having a baby that would help to stimulate further pregnancies down the road. I don't know if there's any history on that.
Well, I think what you'll find is that it depends. It's kind of no one size fits all. You will get some women who've had a really difficult journey getting pregnant the first time. And once they've had that first baby, they then go on to have baby number 2 and baby number 3 with absolutely no issues at all. But then you will also get women who have secondary infertility. So they've had their first baby and had that without any problem at all, and then hit issues, and that can be male factor as well as female factor. A lot can happen in a very short space of time, you know, or there could be a reproductive condition or a bacterial infection they've developed since having their first baby. They could have had difficult birth, and then that will impact upon them having their second. So it kind of works both ways. Thank you, Carol. That's lovely.
I have a question.
Lovely, Anne-Marie.
Thanks for having us today. I was just wondering, I don't know if I missed it or not, but can we purchase the guide from you or take like courses with you, or because we're far away? I was just wondering, are the charts that you have, are we able to buy them?
So the book, you can buy the book on Amazon. That's really easy to access on Amazon. And we do run, all the courses are online, and we have lots of people actually from Canada and Australia and America and other countries who do come and join the training. And I do run international courses, which are slightly later in the day here. So I run them from 2 o'clock till in the afternoon here till 8 o'clock, so that it's at a more reasonable time. So, and you'll find all of that information on the Seron Natural Fertility website. All the course information is on there.
Do you have courses on labor and delivery?
I don't cover pregnancy because I hope that there are so many other people who are so much better qualified than me to do that. So all of the teaching that I do is about fertility or reproductive health. Mm-hmm. The person I usually recommend who has got an online course is Sally Earlham. She does a very good, she's a nurse, and she does a very good maternity reflexology course.
Thank you.
That's okay. Pleasure. Okay. How are we doing, Dale?
I think we're just about ready to wrap up. Are there any more questions before we do that? Okay. Barbara, thank you so much for doing this webinar for us. I know all of our members will enjoy it, and you've stimulated our minds, and hopefully all of us will look more into reproductive reflexology. Thank you. Have a great day.
Thank you.
Thank you for coming, ladies.
Thank you everyone for coming and joining in and listening. It's been such a pleasure to be with you. So, and thank you for having me, Dale. I'm just delighted to be here.
Great. Bye, everybody.
Thank you.
Bye. Thank you.
Bye bye.